Okay, let's get back to the topic at hand. We are going to talk a little bit about the periodontal examination. This is what you're going to find you're spending most of your time, at least in the beginning, doing with your patients, doing medical history, EOIO, and then you take radiographs, then you begin your perio assessment, and it goes on forever. And that sometimes can take you, if you're doing a full mouth, it can take you just that process alone close to a full appointment. So it is quite time consuming, but this is one of the most important things that we do for our patient, because we are collecting all the data to convert that into something that we can use and the dentist can use to make a proper diagnosis on the state of health or disease that the patient has at that time. And then we can develop a treatment plan according to what their individual needs are. So the boards go into a lot as far as the periodontal exam, and again, this is one of the main reasons why dental hygienists get sued, is for not properly diagnosing periodontal disease. Now, are we allowed to diagnose? No. But what we are charged with by our Practice Act is that we are gathering all the data.
Can I interrupt you? I cannot access to the PowerPoint. It says still locked.
Can you see my screen?
I can see on your screen.
It's the one on the bottom. It just says week 7 lecture. The PowerPoint is in there.
Oh, okay. Well, do you want to take a break so I can see what I'm doing?
Alrighty.
Or do you want to keep going?
If you click on
week 7 lecture,
PowerPoint is in there.
So the PowerPoint is in there?
yes.
Yes, it's just under week 7 lecture.
Oh, yes. Okay.
Ha, so this time it wasn't me, was it? Okay, well, let's get back. So you are responsible for determining the state of health or disease with your patient. Some dentists will allow you to write down the diagnosis. We expect you to determine what the diagnosis is. At school, most offices will expect you to do that, and it's up to the dentist then to confirm that diagnosis, because we are not allowed to diagnose. So you have to understand what's involved in this entire process. You need to know the components of a comprehensive periodontal exam, what instruments need to be used, and you have all of them already, you've done them. Explain the technique of what you're doing to your patient so they understand, and explain how the procedure will be described to the patient. So what is your basic setup? And in offices, we'll call them a basic setup. You know, you have a new patient coming in, you might not need to have your entire cassette out with your 20,000 instruments. You might just have a mirror and a probe and an explorer. Excuse me, and that's fine. And some of our students will do that too. They'll get extra instruments for the patient's first appointment. Mouth mirror, probes, your neighbor's probe or furcation probe. This is saying a plastic probe because you don't know if your patient has implants or not. And a subgingival explorer, like your ODU explorer. We usually don't have both explorers in a kit. Mouth mirror, you know the uses. This was on the test. If you are going to be using indirect vision with your mouth mirror, what clock position will you be sitting in if you're a right-handed clinician?
9 o'clock.
Who said that?
Michaela.
No, and 9 o'clock is correct because you're sitting at the 9 o'clock position. You have your mirror so you can look at the mirror and onto the lingual surfaces. If you're in the 12 o'clock position, excuse me, I've got the hiccups again, you can use direct vision, but you're using illumination, okay, or transillumination to take a look at those teeth. What tricks have you all learned, those of you that have been in private practice, to help maintain a clear vision on your mirror?
You mean like as if the mirror getting foggy?
Yeah, foggy, messy, whatever.
Blowing air into it.
Blowing air into it, warming the mirror a little bit on the cheek. Cold air, cold mirror, warm, moist air, you're going to get fogging. So sometimes warming the mirror. There's some people have a cotton roll place that is soaked in either a mouthwash or a special anti-fogging solution, and they just slightly wipe the mirror head with that. So there's solutions that you can purchase as well, but having a 2x2 gauze at the ready, not on the patient's chest, but on your tray, that you can also wipe the mirror head with, because the clearer the mirror is, the more you're going to be able to see. Air water syringe, we are using them minimally right now because of aerosols, but air is your friend, especially when you're trying to detect supragingival calculus on the mandibular anterior teeth. You dry, 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 and then you dry a little bit more. And if you've got just a little bit of supragingival calculus, it's going to turn very chalky and have a different texture and color than the enamel. So our explorers, as you know, detect by tactile sensitivity for the texture of everything. And that will help to define the extent of instrumentation needed, as well as guide your techniques. Have you completed this surface? Do you need to go back in? Is there still a little bit of roughness? Now, in actuality, we don't have an explorer out all the time. When we're doing a periodontal assessment, we are using our probe as our explorer because it's a very thin, needle-like instrument, and we can feel with the probe as we're doing our periodontal assessment and our probe readings if there's calculus there or not. But there are specific explorers, okay? You've got your ODU explorer, your 1112, and your 2317. Do you know which end is the 23 and which end is the 17? You should have these known so that you can, if we say the shepherd's hook, you know which one we're talking about, or if we say the 23, you know what we're talking about. Different explorers. Shepherd's hook. This is a single-ended, a single end, number 17. The one you have has both of these. So the shepherd's hook here is for detecting caries. This is for calculus detection subgingivally on the straight facial, straight lingual, as well as anterior. This is your ODU 1112 that has more bends to it. It's got a couple of elbows. It's a universal explorer. So you can use this both anterior and posteriorly. Then you've got your pigtail or cow horn explorer. And this was the technology that I had when I was in school. And you can only use it for short or shallower pockets. It's got a very big curve here, so you can't get it subgingivally very much. And this is just got a little 90-degree end here. So your employer is going to have an array of instruments in their junk drawer. Every dentist has more than one junk drawer because they bring all their instruments they went to dental school with, no matter how long ago, and everything else that they've purchased since. And They use once and then they put them in the drawer. Explorers, you're counting on your sensory stimuli, that tactile sensitivity, and your fingers need to interpret the difference between normal, smoothness and roughnesses, irregularities, increases in elevation, and then irregularities, depressions, or grooves. Is this elevation a part of the tooth, part of the root, or is it calculus? And that takes experience, which is what you'll be getting as you work your way through us. For supragingival, you're using direct vision. For subgingival, we are relying on our tactile sensitivity to interpret what we're feeling. This is an ODU 1112. This is what it looks like when you are using it properly subgingivally. You're using the side tip, all right, and you're making short, bobbing up and down, up and down. You're doing horizontal strokes. This is more of a vertical. This is an oblique because what you want to do is cover the entire surface subgingivally. You usually probe first and then you explore. But there's different probes. You've seen this picture before. This is similar. This one has more lines on it than used because this goes up to 15 millimeters. This is a color-coded 3, 6, 9, 12. This I have only seen once. I can't stand it because there's no darkness in here. This is flat. This is a Williams marking 1, 2, 3, 5, 7, 8, 9, but it's flat. So it's nice to get on the straight facials and straight linguals if you've got really tight tissue. Another probe and another one, Williams, 1, 2, 3, 4 is missing. So that's 5, 6 is missing, 7, 8, 9, 10. So you can see if you come across a room that has one of these like B in it and you've never seen it before, and when I was doing temping, I was coming across all sorts of probes. I had to think about it. Which probe is this? Is this 2 millimeters or 3 millimeters? Is this 3 millimeters or 5 millimeters? So it really slows everybody down. And sometimes you could be interpreting it incorrectly, which means your probing is off. So it's nice to have the entire office, all the rooms, have the exact same probe. It makes life so much easier. Furcation probes, this is your neighbor's probe. We will show you how to use these. It's really difficult to get the concept of it because you all don't have furcations, but it's got a curve here to go into, all right, the crotch of the tooth. Right, so this is the roof of this furcation. When you've got a straight probe and there's furcation area, you're not able to see how far can that explorer or that probe go. So they make them curvy. Does it just go into the roof a little bit? Does it go almost all the way through? Does it go all the way through and come out the other end? And all those have classification types. But you want to assess the periodontal status to create a treatment plan and educate the patient on what they need. You need to determine the clinical attachment level. Remember those numbers we were talking about? You've got your visible recession, your invisible recession, and how much attachment is really there around the tooth. You're conducting a mucogingival examination. You're measuring where that mucogingival line is. You're entering that into the computer. You're making other gingival determinations. Are there mucogingival defects? Is there overgrowth? That type of stuff. All of this is going to guide your treatment that you're recommending for your patient. It will also help you evaluate the success and completeness of your treatment. You're done. You've done everything you can. Did it work? Did it not work? Is it just one or two areas that aren't resolving? And why? So this will also help you evaluate at continuing care as well as their periodontal maintenance appointments. Mucogingival examination, you're taking lots and lots of measurements. You're taking your probe reading, okay? And so this would be 1, 2, 3, okay? 1, 2, 3, and then this is 4. This is probably up to a 5 millimeter probe reading, but they have visible recession here as well. So you're not only doing the probe reading, you're measuring where that gingival margin is. So you're measuring from the CEJ to the gingival margin, and you're putting that data in, and you're combining the two to come up with your clinical attachment level. How much attachment have they lost? Clinical attachment loss also. Remember that bone should be about 2 millimeters subgingivally. The junctional epithelium is right about at the CEJ, right below the CEJ. So if you've got visible or invisible recession, you have attachment loss. Anytime there is attachment loss, we call it apical migration of that junctional epithelium. You have periodontal disease. So our probing is going to guide us in all of that. And probing technique is very important, and it does vary from clinician to clinician and time to time. That's why we give ourselves plus or minus 1 millimeter. So if we're sitting down to do a periodontal assessment and we're trying to grade you, somebody could have, Jody is there and she's telling me she got a 323 and a 323, and I'm getting a 212, 212. We're still within that 1 millimeter. Jody's telling me she got a 323, 323, and I'm getting a 545, 545. That is a significant difference. If it's more than 1 millimeter, we're taking a look at it, okay? But even if Jody sits down and does it again, she might be a millimeter off from what she was doing the last time. So if it's within that millimeter, plus or minus, there's no significant change. Proper angulation. You want to tilt that probe into the caul area and right it up. But before you even pick up an instrument, you're bringing the patient back from the reception room. Are they walking okay? Do they hobble? Do they need assistance? What do they look like? The color of their skin and everything else. You're reviewing their medical history. What medications are they on? What do they have a history of? What are their familial histories? Also, what runs in their family? You're taking their dental and psychosocial history. You're doing vital signs after all of that. Then you're getting checked, and then you can do the extraoral, intraoral examination. And after you do that, you get checked again with the instructor. So you're going to be having lots of checks. You're also doing risk assessments. When after the EO-IO, at that same time, with you have a new patient in the chair or a recare patient, you're doing a caries risk assessment. And it's a form. Lots of offices use different forms, but it's the same goal is, what is your caries risk? What's the likelihood that you are going to have breakdown of tooth structure? There is an oral cancer caries risk. There is a periodontal disease risk assessment as well. So there's all sorts of risk assessments that are out there. We're doing caries risk assessment to determine how frequently do you think you need that patient to be irradiated. We like to have a full series of x-rays on our new patients coming in to see us. Or if they're an established patient, when were their last x-rays because no longer are we doing it by a time interval. Oh, Mrs. Smith, it's been a year since we've had your routine bite wings. Time to take your bite wings again. We're not doing that. We're saying, Mrs. Smith, Dr. Jones has asked me to update your x-rays or your bite wing radiographs so Dr. Jones can have a new view of what's going on between your teeth or underneath your crowns or whatever it is. You're giving them a reason, not because it's time for their routine x-rays. Do they need them every 6 months, every year, every 18 months, every 2 years? How frequently do they need a full series? Excuse me, I only need, quote unquote, need bite wings taken maybe every 18 months. I've never had a cavity between my teeth. I have broken some teeth. My 6s are, you know, they're old, so they've broken. But anyway, I end up getting more radiographs that I need because you all need to be able to graduate. So a lot of times the instructors will sit down and go, yeah, go ahead and zap me. But I don't need them. And during the morning huddle, this is when I go into my spiel with the doctor too. Sarah Jones is coming in. She's class 1 Perio, never had any interproximal decay, blah, blah, blah. It's been a year since she's had her last bite wings. Can we put them off for another 6 months? The patient is really grateful if you can approach them and say, hey, good luck. You know, we've got good news here. So that's the radiographic examination. The dental examination, oftentimes you are the one that the patient will be seeing first if your office is set up that way and they don't see the dentist and the assistant first for a comprehensive exam. So you're doing the initial crossing out missing teeth, charting existing restorations and that type of thing. And you're also determining the type of deposits that are on their teeth. We've gone over the procedure itself, so we don't need to deal with that. Proper angulation is important. Look at the difference between these two teeth. Tooth number A is a deciduous tooth. Tooth number B is not. A is deciduous because it's much more curvy. It's got a pinched in waist. The nice thing about having computerized printouts is that it will compare one visit to the next as well. But look at the different probe readings here. They can look very different. The pocket is the same on all of them. The reading is the same on all of them. But on some of them, you might have to think about it a little bit more. So if I had this particular probe, this is the one I am not familiar with. I've only seen it a couple times. I would have to lift this up just a little bit to see where that line is so I can get my bearings. Same way with this. Where are the lines? This I know, this I know. I can just call out those numbers and you will be able to call out those numbers very quickly also. So you're probing
Miss
higher.
E,
I'm sorry?
I think someone have a question as well.
Yeah.
I just have a question back to the previous slide, the slide that you have the DCS tooth. So I just wonder that if the patient had the DCS tooth, we still have to probe that even though they don't have the primary tooth?
Oh, yes. Well, an adult patient. We're not having you probe kids.
Yes, that's what I wonder.
Yeah, no, but if they've got a retained deciduous tooth, and it's more common on the mandible than it is on the maxilla, if they've got a retained deciduous tooth and they're missing a premolar, you're probing that. But for children, you're doing gingival margin and mucogingival line only.
Oh, okay. So what's the specific age that we can probe?
fully erupted permanent teeth is
Fully
the
erupted.
policy that we have.
Okay. Alrighty. All right. Thank you very much.
Mhm. So some of the sources for errors in periodontal probing can be angulation. One, I remember years ago, there was a, oh, I just lost my name for it. But anyway, there was a practice management consultant going in to the office next door to me, and they were told to not upright the probe when you're going interproximally. Keep it angled. Remember, you angle it just a little bit and then you upright it some. And if you keep it angled, it will give you at least a 1 millimeter greater reading, and you'll be able to quote unquote sell more scaling and root planing because you'll have more periodontally involved patients. I am horrified with stuff like that. So angulation is important. So is the thickness of the probe. If you've got a fat probe, it's not going to get into tighter, narrower pockets as easily as a thin, narrow probe. Short walking strokes, keeping it underneath the tissue the entire time, so you're not missing anything. You're taking 6 readings. Clinical attachment level, how much attachment is around the tooth, how much attachment, where are those periodontal ligaments? We want a bunch of them, and we want a bunch of bone around each tooth to support the tooth. Have you lost any? And if you've lost, how much have you lost? So that's what the clinical attachment is all about. So for this, you can see that the bone and the gum tissue, or the bone and the junctional epithelium, is at the same place. However, you've got tissue that's swollen and puffy, tissue that's receded a little bit, tissue that's at the CEJ. So these are going to be very different readings, but your clinical attachment level is going to be the same. Mucogingival defects, you have seen some pictures of those where you have 1 millimeter or less of attached tissue. All right, you run the risk of losing the tooth if you lose the attachment. That junctional epithelium is a barrier for bacteria to go all the way down the root of the tooth. If you don't have that thin barrier, bacteria is going to go in there. So you're looking for mucogingival defects, and the wrinkle or fold test is placing the probe horizontally here, and then you're pushing just a little bit because this mucosa is not attached, and you'll see a little bit of a wrinkle here. Sometimes you can't see a demarcation line. Measuring the attached gingiva, where is the gingival margin to that mucogingival line? And then what is your probing depth? You're checking for mobility. You're taking the ends of 2 instruments and checking. Do they wiggle just a little bit? More than a millimeter? Less than a millimeter? Can you depress it? Mandibular anterior, the incisors, we can see just some microscopic, a little bit of wiggling, less than a millimeter. And that is normal because the teeth are not ankylosed, they are in a hammock of our periodontal ligaments. So you're checking for mobility. What type of mobility is it? This says the letter N means normal mobility. We don't chart normal, we only chart abnormal because it just puts too many numbers on a chart. Fremitus, you have the patient going, biting up, down, they're tap, tap, tapping, and you're feeling for it. You're checking for vibrations here. Is there a bite discrepancy in the anterior teeth? That's fremitus. Furcation examination, you will have your furcation probe out in all of your setups. I do not use my furcation probe all the time. I like my ODU Explorer because it's so thin and it's got all the bends to it. Can I just get it into the furcation, and am I just feeling the root or the roof of that furcation? Or if I need to, then I'll get my furcation probe out to see how far interproximally or interradicularly does it really go. And there are grades for that, just as there are grades for mobility, 1, 2, and 3. There are grades for furcation, 1, 2, and 3. The lower the number, the less it is. For furcation, it goes 1, 2, 3, 4. Very difficult for the patient to maintain, very difficult for you to clean. You're taking a radiographic survey and you're writing down what you're seeing radiographically. Where is the bone level? Is there horizontal bone loss? Is there vertical bone loss? Is it generalized? Is it localized? Slight, moderate, severe. Normal bone level should be 2 to 3 millimeters apical from the CEJ. You've got a nice crustal bone here. Thin lamina dura. Looks good. If this was a horizontal bite wing, you would not be able to see any bone. But you can see the calculus here. What type of instrument would you want to use here? Would your scaler be able to get that? Would you need a curette? Would you need an area-specific curette? How would you approach that? Vertical bone loss. Have you learned how to go from CEJ to CEJ yet to see if it's vertical or horizontal?
Yes.
Yes, we
Yes, we did.
Okay, so is it vertical? Is it horizontal? And so that's something that you'll be determining. Very good. You can see this premolar here. This is the first premolar that has that concavity that goes over the mesial marginal ridge. Don't fall asleep on me that you've got that groove that goes over the mesial marginal ridge and goes all the way up the root. You can see that on this radiograph, which is really cool. I'm going in the wrong direction. You're looking at that crustal lamina dura, and this is one reason why we need to have vertical bite wings. They're more difficult to take. They're more difficult to take accurately. Sometimes you, instead of having to do 4 vertical bite wings, you need to do 6 because they're a little bit narrower on how you're placing them. But we get so much more information from them. We're looking at that crustal lamina dura. We're looking for occlusal discrepancies. Is there a widening of that PDL space? Does that crustal bone look like cotton candy, or does it look very nice and have a white outline to it? We're looking for calculus. Now, calculus x-rays aren't really beneficial to detect calculus because only about 45% of the calculus shows up on a radiograph. But you know, if you're seeing it on a radiograph, they got it everywhere, unless it's one area or 2 areas that have just been missed with scaling. But you're checking for calculus. Overhanging restorations, plaque retentive surfaces, you're checking for dental caries. And of course, you're documenting everything. So you've discussed what you've found with the patient. So when the doctor comes in, they are oftentimes reinforcing what you have said. They hear it from you, they hear it from the doctor, and you are both in agreement. So the treatment plan can then be moved forward. So it's really important to tell the patient what you're doing, because if they're just laying there with their mouth open and they don't know that you're doing an oral cancer screening for them, they don't know. They don't know how important the service is that you're doing. Are you charging for it? No, but this is what we do for everybody. Oral cancer, it's very prevalent, shows up in, the sides of the tongue, the floor of the mouth, the back of the throat. We want to make sure, blah, blah, blah. Same way with periodontal disease. It goes undiagnosed. That's what hygienists are getting sued for. Undiagnosed periodontal disease. We can't diagnose, but what happens is the dentist's insurance ends up suing us, their insurance company, because it was our job to find it. So there's all sorts of, this was really, I didn't format this very well, but there's all sorts of pictures that you're going to have at the ready. During your semester break and at the beginning of next semester, you're going to be doing an oral hygiene education book, and you're going to have pictures and other things in there where you're explaining what you're doing and why and what you're finding on your patients. So when you start discussing the periodontal disease, healthy is here, but you are here with periodontitis, where you've started to lose your bone. The bone has become infected and blah, blah, blah. And then you'll be able to educate the patient on what they need. Is there attachment loss? And I would say yes, because the CEJ is exposed. Do you think that patient has pocketing in addition to recession? Don't know. Maybe down here, this tissue looks like it might be a little wobbly, but the facial, that might be only 1 millimeter. So without knowing where that gum tissue is in relation to the root surface, I could be probing 323, 323, 212, 212, 212, and make it seem like I've got very normal, healthy pocket depths, probing depths. But do you really when there's attachment loss like this? I have only seen this a couple of times, and that's been working with special needs. This isn't somebody that you're going to be seeing in our clinic. Where do you even begin? Can you do a comprehensive periodontal exam on this patient? Absolutely not. But you need some sort of documentation in order to send it off to insurance, in order for them to be able to get their benefits used if they've got it.
In that case, Ms. D, do you just start scaling?
It's called an initial debridement, which we don't recommend, but sometimes you have to knock off all of this stuff so you can get down below the gum tissue. Because look at this calculus even on the lingual here. You can't probe that. I'm sorry?
Why would you not recommend the initial debridement?
Because what happens is, we used to call it a gross scale, and the tissue shrinks and gets tighter. So you're leaving 3/4 of the calculus underneath the gum tissue, and that collar along the gum is just tighter. So you're making it more difficult to access.
Okay.
But there is scaling in order to do, sometimes you need to do a debridement, I forget what it's called, in order to do a comprehensive exam. There's a code where you have to do, and you just get as much of this stuff off so that you can do a comprehensive exam. You can't even take radiographs. What's the use of taking radiographs right now?
Yes, that's what I want to ask you.
'Cause
You
this
need to
stuff-
take the X-ray on this.
Well, this stuff, I would take a pan first and then see what the pan says, because if this calculus is so thick and calcified, you're not going to be able to see a lot of the underlying structures,
Right.
okay, because it's blocking the radiation.
Mm-hmm.
Miss D,
Yeah.
So is this possible that some of this teeth came off after the scaling because of?
Oh, yes, very possible. Sometimes the only thing holding things in is the calculus.
Right.
So again, when you're treating
Misty?
a patient, if you know that, I'll get to you in just a second, if you know that they've got severe periodontal disease, you have to let them know the likelihood that your teeth are going to be loose, the likelihood that some of the teeth are going to fall out, the likelihood that you think this patient's going to have scaling, post-scaling sensitivity, those newly exposed root surfaces, oh yeah, they might not be happy, but they have to be aware of it. I'm sorry, I cut somebody off.
You actually answered my question.
Oh, okay.
Yeah. Mhm. Thank
All
you.
right, so you've got to, that's all part of informed consent, the good, the bad, the ugly, and how much it's going to cost. And if we don't do anything, what's it going to do? What's the likelihood? So we've got all sorts of wonderful types of periodontal charts. We are going to educate you on using the computer because most offices have, even though they're not paperless, maybe, they're using computerized periodontal probings, okay, where you're entering your numbers into the computer. Others will still be using paper, and we're going to have you doing paper periodontal assessments as well. You'll be doing both for certain patients throughout your time here because we want you to be familiar with, I can use a computer and I can use paper, and you're telling your prospective employer, I've got it, I can do this. So depending on the computer program, they all work very similarly. We use Dentrix, which is a very popular program, and we'll be getting into that later on in the semester and putting all of these pieces together. All right. That's all I wanted to go over today. Is there any questions or whatever?
Missy, when is the next exam on 141?
I think it's the Tuesday when we get back after spring break or fall break.
Thank you.
And no, I don't know what chapters are on it yet.
I was gonna ask that.
No, I don't know. I'll get that out to you though.
Okay, thank you.
Okay. Any other questions? So before your next clinic, which is not next week, but the week after, get all of your instruments autoclaved, your gray instruments, your Gracies. And I would even have your prophy angle, you don't have that yet. Shoot, you don't have the Dentsply kit. Oh my gosh. Okay, well, never mind. Get your Gracies out.
Miss D, have they given you an update?
The last update I had was they are waiting on patient napkins. And I said, well, we don't need the napkins. Just give us what you've got. And he said it doesn't work that way. So I will be calling today to yet again. I've been calling about twice a day, every day. Trust me.
That's crazy. Okay, thank you.
Yeah. And I've been in touch with the financial aid office and the second floor with the provost and Dr. Cook, who's the assistant dean of allied health, about this whole situation. And they just don't, administration doesn't understand. So anyway, I'm doing what I can, my friends.
Ms. D, our next class is October 20th, correct?
Yes.
And then the test is the test that Tuesday or the following, the 27th?
That Tuesday.
That Tuesday, the 20th. Okay. All right. Thank you.
Miss D, will the kit include N95 masks?
No. They will include level 3 masks. We made these kits before COVID. We put them together, so you'll have level 3 masks. We will supply N95s for you. We don't have it, we can't fit test though. But you'll have a face shield, you'll have level 3 masks, and you'll have safety glasses.
Thank you.
Now, speaking of glasses, the oroscopic rep is going to be doing his show on next Wednesday. So be on the lookout for an email. I don't know how he's going to want to sign up people to make sure that there's social distancing and all this other stuff. He's assured me, and he's very good. So he's assured me everything will be above board, and all the protocols will be followed for safety and disinfected and everything else. So I'm assuming there'd be a sign-up sheet so you can go before or after your radiology and just see what Oroscopic is all about. It's one of the top companies.
And then Miss D, you said that, are we going to be seeing multiple, like different companies in regards to loops, or
Yeah, I usually have had what we call loop day, where I'll bring 3 of them in and they'll talk to you, and then we'll separate them around the clinic, and you get to see 3. I bring in Designs for Vision, Oroscopic, and Q Optics, because they seem to be the most popular loops. And Oroscopic is the only one so far that has been working with me on trying to make something happen for you all.
Okay, thank you.
So some schools make you buy a certain brand. I do not. And I've gotten some flack for it, because you can save like $50 if I promise that, oh, we're an oroscopic school. And it's like, no, you guys need to pick out something that you're comfortable with. When you're spending $1,500 or $2,000 on something you're going to be wearing for the next 10 years, you want it to be what you want.
Ms. D, just want to clarify very final thing that the for exam for this class would be on October 27th or 20th?
No, October 20th.
20th, okay. After fall break. All
Right after fall break, yep.
All right, thank you. Make a note of that.
Okay, any other questions? I wish you luck. You've got what, 2 more exams this week?
Yes, ma'am.
Okay, all right. Good luck with everything.
Thank
you,
you.
Miss D.
Okay, I'm an email away. I'll be on campus tomorrow. So if you need to see me, come and see me.
Thank you, Misty.
Bye.